Good morning, students. So today we are going to study about rules of professional conduct. Rule number 1. Scope of practice. Chartered physiotherapists shall only practice to the extent that they have established, maintained and developed their ability to work safely and competently, and shall ensure that they have appropriate professional liability to cover for that practice. Rule number 2. Relationships with patient. Chartered physiotherapists shall respect and uphold the rights, dignity, and individual sensibilities of every patient. Rule number 3. Confidentiality. Chartered physiotherapists shall ensure that confidentiality and security of information acquired in a professional capacity. Rule number 4. Relationship with professional staff and careers. Chartered physiotherapists shall communicate and cooperate with professional staff and other carers in the interest and with the consent of their patient, and shall avoid inappropriate criticism of any of them. Rule number 5. Duty of report. Chartered physiotherapists have a duty of report to an appropriate authority circumstances which may put patients or others at risk. Rule number 6, that is advertising. Chartered physiotherapists shall ensure that advertising in respect of their professional activities is accurate and professionally restrained. Rule number 7. Sales of services and goods. Chartered physiotherapists shall not sell, supply, endorse, or promote the sale of services or goods in ways which exploit the professional relationship with their patient. Rule number 8. This is personal and professional standards. Chartered physiotherapists shall adhere at all times to personal and professional standards which reflect credit on the profession, behavior, approach, and dress should not cause offense to the patient and carer. Our profession has 3 specific characteristics. 1. A unique body of knowledge. 2. A set of rules, codes of conduct based on acknowledged ethical principles. 3. And the ability to discipline members who contravene those rules in ways amounting to serious professional misconduct. Now we are going to read all these rules in details. Again, the rule number 1, this is scope of practice. Chartered physiotherapists shall only practice to the extent that they have established, maintained, and developed their ability to work safely and competently, and shall ensure that they have appropriate professional liability cover for that practice. Scope of the practice of the profession physiotherapy is an applied science which possesses its knowledge base, its own educational methods, and practical application based on that knowledge. This is supported by the best available evidence of effectiveness. Physiotherapy research links theory and developing practice. This practice has at the same time retained its links to three core skills. And these three core skills are: first one is manual therapy, including massage, mobilization and manipulation, electrotherapy, and exercise and movement. A profession's scope of practice encompasses those areas that its members are educated for, competent in, and ensured to provide. The overall scope of practice of the physiotherapy profession encompasses all individual physiotherapists. It scopes and sets the outer limits of practice for all physiotherapy practitioners. For those physiotherapists practicing as extended scope practitioner, the element which extend their scope fall outside the general overall scope of the profession. Scope of the practice of the individual. Within the overall scope of practice of physiotherapy, individual physiotherapists practice within their own individual scope. This may be described in general terms by some or all of the following. The one is occupational role. For example, researcher, clinician. Second, sector. For example, NHS, private practice, industry, and higher education. Third one, that is environment. For example, acute or primary care. Next is client group. For example, children, older people, people with learning difficulties. Next, that is a specialty. For example, women's health, neurology, musculoskeletal disorders. The next is treatment approaches and techniques. For example, hydrotherapy, acupuncture, boba, this type of cases that the individual refers elsewhere. Example to other physiotherapists. More specifically, members need to consider their individual scope of practice in relation to individual patients or circumstances. When presented with a patient, the physiotherapist should ask the following key questions before proceeding. Question number 1. Can I justify the decisions I have made during the assessment? For example, has the research evidence been considered? Question number 2. Can I identify the most appropriate approach for the patient? Question number 3. Do I have the correct balance of skills, knowledge, and experience to be competent in my chosen approach? By answering all these questions, the physiotherapist not only identifies and determines the limits of his or her own competence, but also demonstrates an understanding of the scope of the profession of physiotherapy. The individual is also illustrating an awareness of other approaches, which may be of more benefit to the patient, including referral to another physiotherapist. This approach ensures that every interaction is a learning experience. which will not only inform but may change and develop that individual's own scope of practice. Inevitably, development in one area of practice will be balanced by the dilution or diminution of skills in another area of professional work. But by following the questions set out above, an individual is able to appreciate the limit of his or her own scope, ensuring safe and effective practice in the best interest of patient care. Competence Continuing Professional Development, that is CPD. Now let's talk about CPD. Members of the CSP undertake an initial qualification validated by both the CSP and the Physiotherapist Board of the Council for the Profession Supplementary to Medicine, that is CPSN, or the Health Professions Council from April 2002. This ensures a level of competency that is expected to ensure safe and beneficial practice by that practitioner. Both the profession and the health and social care arena in which physiotherapy is practiced are subject to consent or rapid change. Every physiotherapist must keep up to date and must engage actively in a constant process of learning and development. The integration of CPT into day-to-day practice benefits the individual by enhancing and developing his or her own performance, which in turn will benefit the patient and the service. CPD activities should be planned in accordance with a thorough and ongoing evaluation of the individual's learning needs and recorded in his or her portfolio. As members of a dynamic and changing profession, physiotherapists have steadily employed and included in the repertoire of physiotherapy a range of treatment modalities and philosophies, which may continue to be modified or developed. But the process must not be developed to such an extent that the member is, in fact, practicing another profession under the guise of physiotherapy. This would challenge the professional accountability, which is so important to protect patients. However, members clearly needs to be able to find out whether a given technique is part of the practice of physiotherapy or whether its use represents the practice of non-physiotherapeutic healthcare. The following is guidance to members wishing to explore new developments in their practice. The new modality, technique, or philosophy is clearly based upon the core skills of physiotherapy. Evaluative research is being or has been undertaken into the innovative practice and it has been shown to be beneficial. Education relevant to the practice should be undertaken by the physiotherapist using it in accordance with this rule. Members exploring new ideas should seek out other members and other professionals who are involved in exploring the same or similar ideas. They should discuss with them the effects of the new approach, the theoretical underpinning, the uses and contraindications, and the education and professional issues relating to the areas being investigated. Published research that has been carried out should also be considered. The next is members should at all times recognize the responsibilities of their professional practice, that is, that they should always benefit the patient through the exercise of professional knowledge and skills acquired through educational and experience. In some cases, there will be no question that the new technique falls within the scope of physiotherapy, since it will be development of well-established procedures. In other cases, advice may be sought from the society. 4. Duty of care, civil liability. When a patient is received for assessment and treatment by a physiotherapist, the legal and professional duty of care towards the patient is established. Physiotherapists have a responsibility to ensure that the therapeutic intervention is intended to be of benefit to the patient. This responsibility requires physiotherapists to keep up to date with the evidence-based developments in their area of practice and expertise. This evidence may be in the form of clinical guidelines, evidence-based care pathways, or research findings which, following rigorous review, are robust enough to inform best practice. Members should be aware that they have a common law duty of care to their patients, and that a breach of this duty may lead to a civil claim for damages by the patient. The duty arises wherever a practitioner holds him or herself out as ready to give professional advice or their treatment. A breach of the duty of care to the patient may give rise to a claim for damages for negligence by the patient. A breach of this duty may be tested as follows. The standard of care the practitioner must use is a reasonable degree of the skill and the knowledge. In other words, neither the highest nor the lowest degree of care and competence. A practitioner will not be guilty of negligence just because someone of greater skill and knowledge would have used a different treatment. Professional liability insurance. Practicing the profession of physiotherapy has its risk. It is therefore important that any risks are covered by adequate insurance. In the employed situation, physiotherapists are vicariously covered by the employer. Physiotherapists should ascertain from their employer the level and extent of that the serious responsibility at the start of their employment. It is important that members do not extend their practice in such a way that is unknown or unacceptable to the employer. Doing this could mean that if an incident occurs in respect of that modality and litigation follows, the employer may not accept liability. Some independent hospitals and other employers do not cover their employees. It is important that the physiotherapist is aware of what cover, if any, is offered by their employer. It is the responsibility of individual chartered physiotherapists to check on their professional liability cover. For physiotherapists working independently, it is usual for the practitioner who treated to be sued. However, in some circumstances, the business clinic may be sued either separately or with the practitioner. It is therefore advisable for the business to be covered as well as the practitioner. Sixth one is delegation. Delegation of appropriate tasks to others is an important way of ensuring that effective use of physiotherapy resources occurs. Tasks delegated must be supported by a responsible body of opinion within the profession and by research evidence where this is available. If a physiotherapist decides to delegate physiotherapy care and or a task to an assistant, he or she must ensure that assistant is safe and competent to carry out this care or task. If not, the task should not be delegated. The physiotherapist can refuse to delegate a task or stop an assistant undertaking an activity if, in her or his opinion, the assistant has not been adequately trained, it is unsafe or not competent. The assistant also has the right to decline to carry out tasks which he or she is not competent to perform. Rule number 2, that is relationship with patient. Chartered physiotherapists shall respect and uphold the rights, dignity, and individual sensibilities of every patient. Respect for the patient as an individual is central to all aspects of the physiotherapeutic relationship and is demonstrated at all times. This rule covers a wide range of legal rights, including the Human Rights Act 1999, Disability Discrimination Act of 1995, Sex Discrimination Act of 1998, and the Race Relations Act of 1976. It also covers civil rights arising from common and case law. This includes the right to have cultural customs respected, right to privacy, the right to complain, and the right to have a complaint dealt with appropriately. Equal opportunities issues and the concept of informed consent are also encompassed within this law. Informed consents. Now let's tell you about what are informed consents. In general, a patient would be considered to have the capacity to give or withhold consent if capable of, that are comprehensive and retaining treatment information, believing such informations, weighing such information in balance, and arriving at a choice. Patients deserve to know the truth, to participate in decision making, to refuse to be used for teaching, and to be given full care even when their choice differ from the therapist. All information relating to informed consent emphasizes the following. A patient's Informed consent must be obtained before carrying out any form of examination or treatment. Information must be given to the patient as clearly as possible to avoid ambiguity. Treatment options must be discussed with the patient and include information about significant benefits, risk, or the side effects. Alternative approaches that could be offered by other professionals or by physiotherapists should also be discussed with the patient. This gives the patient, if appropriate, a choice of treatments and a full understanding of what the physiotherapist purpose is. The therapist must ensure that the patient has the opportunity to ask questions and is encouraged to do so. Patient must be informed of their right to decline treatment at any stage without it prejudicing their future care. Consent or the declining of treatment must be documented in the patient's record with the reasons of declining. Patients involved in the decision-making process. Patients need to be involved in any decision-making process during treatment planning and in any subsequent refining of this. This process is particularly important in physiotherapy, which is a dynamic, interactive process involving the patient. With the consent of the patient, named physiotherapy procedures are applied to the patient, for example, electrotherapy or manipulation, or performed voluntarily by patient under guidance. How consent can be obtained? The main question. Let's look at the answer. Following the above, consent may be implied, for example, by the patient positioning himself or herself for therapy, or it may be expressed either by words of mouth or in writing. With the majority of physiotherapy interventions, consent by implication or word of mouth is quite sufficient. However, it is considered good practice to document in the patient's notes the fact that consent has been obtained. The use of tick boxes is no longer acceptable, and whereas a signature on a consent form does not itself prove that consent is valid. The point of the form is to record the patient's decision and also increasingly the discussion that have taken place. There are some specific physiotherapy procedures where it may help to have written consent. For example, movements of force to the cervical spine, vaginal and rectal examination, nasopharyngeal and tracheal catheter suction with competent patients and exercise tolerance test for patients with cardiac conditions. When written consent is required and forms are used, some indications of the information given, the options offered, and how consent was received should be included to ensure the form has legal credibility. Clinical and occupational groups may provide guidance on this issue, and employers may already have policies which must be followed for particular interventions. Now, the big question arises that what if a patient refuses treatment? A person is entitled to refuse treatment even if the treatment is life-saving or even if the reasons for withholding consent are considered rational, unknown, or non-existent. It is illegal to force physiotherapy on patients who resist or who are unable to resist but have made their wishes clear by words or gesture prior to becoming incompetent. Patients may withdraw consent during treatment if patients do not know that they have this right. They should be informed. In the face of refusal, physiotherapists should seek to pursue it, a change of mind, but must not use duress or deceit. Summary of consent issues. Mere presence of a patient does not imply consent to treatment only, to attending for the appointment. A contractual relationship between a patient and physiotherapist, such as payment for treatment, does not imply consent. Informed consent demands that the patient understands in layperson terms all the advantages and disadvantages of the proposed treatment regime. It may be practical to present a written explanation before the first, then test understanding again, or provide further information prior to assessment and the treatment. If patients are not offered as much information as they reasonably need to make their decision, and in a form they understand their consent may not be valid. At all stages of assessment and treatment, it is essential that the physiotherapist is satisfied that valid consent has been obtained, including situations where global consent has been given for other disciplines. Besides physiotherapy to be included in an integrated care pathway, consent may be implied, for example, by the patient self-positioning for therapy by word of mouth or in writing. The physiotherapist should document in the clinical notes when consent is received, either implied or expressed. For high-risk or invasive procedures, written consent may be obtained. For example, graduated mobilization and manipulation may lead to grade B cervical manipulation being used as a progression of the treatment. The physiotherapist is not accepted to interrupt the rhythm or flow of a procedure to ask for a signature, but should ensure that the patient is given appropriate information and is in agreement to the progression of the treatment, and that due care has, has been taken when assessing the patient for the suitability of the technique. Other examples include vaginal and rectal examinations. Also, catheter suction and exercise tolerance test on the patient with cardiac conditions. Unlawful touching, even therapeutic touching that is without the consent of the patient, comes within the scope of criminal offense of assault and battery and the possible civil action of trespass to the person. Emergency treatment may exclude the possibility of formal consent, for example, an acutely painful condition for a sports field injury. The following conditions allow treatment without consent. Unconscious patients are deemed to have consented to all interventions to maintain life and limb. Any treatment decisions made before the patient becomes unconscious should, however, be taken into account. Common law power to act out of necessity. Patient incompetence, acute pain, and immobility in an emergency situation. Refusal of treatment and subsequent action must be documented, and any decisions discussed with the team. Relatives cannot give valid consent for adult patients unless they have specific powers granted by the court. Their opinion should, however, be considered and respected. Even where a patient is unable to give or refuse consent, any reaction, for example, distress, should be considered in the team discussion. Other issues affecting the informed consent process. Much has been written about the informed consent process, and members are recommended to read as widely as possible on this subject. The following are additional issues for consideration. Balance of power. So let's have a look at balance of power. Patients are often either in an undressed state, in bed, or on a couch. The therapist is distressed in a uniform and in a standing position. This means that the therapist is in a position of power with the patient in the position of submission. Additionally, the patient may be in a pain or afraid and in unfamiliar surrounding. The therapist having the power of relieving the pain, anxiety, and impairment. Physical impairment. This inequality can inhibit the exchange of information, perhaps depriving the therapist of vital knowledge affecting the care of the patient. Next is environment. Hospitals and their physiotherapy departments may be intimidating places, and patients may need to be reassured and supported while they become accustomed to unfamiliar surroundings. GP surgeries and physiotherapist private practices may be less intimidating. In the domiciliary situation, the patient may be in the dominant position, and sensitivity to the situation, which is needed to ensure that the appropriate flow of information takes place and the therapeutic relationship is established. Consent of research. Patients, people who may be potential research subjects, such make an informed decision as to whether to enroll or continue to participate in any study. Subjects should be fully informed about the purpose of research, its procedures, potential risks, potential benefits, and alternatives, especially if treatment may not be funded or available other than through the trials. They should be given the opportunity to ask the question and also to be informed of their rights to decline to participate in the physiotherapy research at any stage without it. Prejudicing their future care. Further information is available in the NHS Research Governance document, Research Governance Framework for Health and Social Care. Touching patients. The very nature of the practice of what is primarily a handling profession means that physiotherapist handles patients when examining, testing muscle strength, assessing tone and measuring range of movement, or during treatment when instructing and positioning, facilitating movement, massage, mobilization, manipulation, and so on. Patients are often in a state of undress, and close contact may be made with the patient in the implementation of a particular regime or treatment. This handling and contact must be carefully explained, permission obtained to ensure that the patient is adequately prepared. Otherwise, practice is open to misunderstanding and misinterpretation, which can lay a member open to allegations of assault or even indecent assault. Therefore, consent must be sought from patients prior to the commencement of any assessment leading to the treatment and before any of the contact is made. Patient may have valid reasons for not wishing to remove clothing or to be touched, which may not constitute an overall refusal of treatment. Physiotherapists need to be sensitive to these possibilities. The therapist should offer a full explanation that this action by the patient will not necessarily result in a refusal to treat but may require a modification of the treatment. In many cases, it is essential to remove clothes, otherwise, the therapist must be negligent in failing to observe significant symptoms such as colors of the skin, tumors, etc., for which the proposed treatment may be contraindicated. Treatment may be possible with clothes on, but assessment is not. By proceeding to treat the patient with clothes on and by not touching, the patient's confidence and cooperation may be gained, leading to consent to undressed. In the best practice, the physiotherapist should explain what is likely to happen during examination and or without the formality of asking if the patient may be touched by saying, for example, I am just going to hold your leg to see how far the ankle and knees bend. The patient usually gives implied consent to this by offering up the limb, which is to be tested or treated ready for the physiotherapist. Obviously, this cannot happen at all times, and the physiotherapist must exercise professional judgment and common sense. The physiotherapist should be allowed to unspoken signals from the patient as to whether they are comfortable during handling or at all the times the patient must be suitably clothed and appropriate covering must be supplied by the physiotherapist. Record keeping. One of the rights every patient expects is their medical records are full, clear, and held securely. The duty of the physiotherapist as part of the scope of practice and to comply with the patient's right is to ensure that a full physiotherapeutic record is maintained. Core Standards 15 and 14 and Services Standard 19 provide further details. Further information is available in the form of PA information paper, that is PA 47, General Principles of Record Keeping and Access to Health Records. Reluctance to treat a particular patient. It is important that if a physiotherapist has either conscientious or moral objections to treating a patient, these are clearly recognized and discussed with an experienced colleagues. Discussion should also occur if the physiotherapist object to treating a patient on the grounds that the patient's behavior towards the therapist is unacceptable. If, however, the reason for not wishing to treat a patient is because of his or her sex, religion, race, sexual orientation, or medical conditions, it is unlikely that any change of physiotherapist would be appropriate or should be tolerated. Physiotherapists may, from time to time, be required to care for people whose views or behaviors they might find personally unacceptable. When patients expresses views or behave in ways which are offensive or harmful to their physiotherapists are entitled to take a reasonable steps to protect both themselves and others. This requires considerable tact and sensitivity. Physiotherapists must not respond in an abusive manner to physical or verbal abuse. Physiotherapists can, however, make patients aware when their behavior has become unacceptable or potentially harmful to themselves, to other staffs, or to other patients. If, in the therapist's opinion, a patient may be dangerous or unstable, treatment can be withheld in the employed setting referral to or the seeking of advice from an experienced colleague is important. In the self-employed sector, where the contract is directly between the therapist and the patient, the therapist may refuse to treat a patient. And the circumstances, it is important that any referring medical practitioner is informed and inappropriate an explanation should be given to the patient. And here comes the rule number 3, that is confidentiality. Chartered physiotherapists shall ensure that the confidentiality and security of information acquired in a professional capacity. This rule outlines the physiotherapist's responsibilities in relations to confidentiality and security of information gained by him or her during the course of practice. All the information which the patient gives to the physiotherapist is treated in the strictest confidence. All personal, like example, clerical or reception staff involved with patients in the delivery of physiotherapy service should be made aware of and adhere to all aspects of this rule. The following bullet points give you the example and offers guidance as to how to deal with some of the complex situations which arise in respect of confidentiality. If a telephone call is received in a physiotherapy department, unless the physiotherapist is confident that they recognize the voice of an anxious relative, the caller must be informed that no information about the patient can be divulged. Messages from the physiotherapist should not be left on patient's unscreened answer phone without permission. Information relating to confirmation of an appointment and or notification of attendance of physiotherapy must be treated as confidential. Comes next to the rule number 4, that is relationship with the professional staff and carers. Chartered physiotherapists shall communicate and cooperate with professional staff and other carers in the interest and with the consents of their patients and shall avoid inappropriate criticism of any of them. This rule relates to the cooperation and communication which physiotherapists are accepted to undertake when dealing with the professionals and others associated with the care of their patients. Physiotherapists shall work in such a way as to promote good health in a clinically effective manner with due consideration of a cost, This may involve working in various locations and within multidisciplinary and interagency teams. Physiotherapy is an autonomous profession, and the responsibility for assessment and subsequent treatment remains with individual physiotherapists. Written or verbal referrals may be accepted from all sources, for example, medical practitioner, other health professional, and self-referral. Chartered physiotherapists are reminded that they are legally liable for the treatment, teaching, and advice carried out following assessment. This applies regardless of whether the treatment requested by a medical practitioner is found to be appropriate following assessment of the patient by the physiotherapist and is subsequently carried out or not. In some access to the service by operating or medical referral on the system, it should be openly acknowledged that this referral system is not a requirement of professional physiotherapy practice but is employed as a management strategy. Rule number 4 does not preclude chartered physiotherapists from working only from a written medical referral. However, the responsibility for physiotherapy assessment and treatment is that of the chartered physiotherapist. Opting to work is this way does not lessen their responsibility in any way. Chartered physiotherapists have threefold responsibility to ensure that intervention on the basis of their assessment is necessary and appropriate. The one to the patient to make sure that expectations are not raised that cannot be fulfilled, and not to waste time and or treat patients to whom the treatment would not be beneficial or has ceased to be beneficial to themselves by treating a patient who does not require such treatment. A chartered physiotherapist could be in contraventions of a rule of professional conduct. It is morally wrong to give a treatment when it is not required or when referral to another agency is necessary or more appropriate. To the employers, whether self-employed or employed through a health trust, private hospital, or industrial concern, it is ethically wrong to waste time and money by treating patients unnecessarily. Rule number 5, that is duty to report. Chartered physiotherapists have a duty to report to an appropriate authority circumstances which may be putting patients or other at risk. Therapists work within a variety of environments, both within or outside the hospital setting. All environments can present risk for the patients, carers, and therapists. From the obvious, for example, steep stairs without grab rails in the home situation, to the less obvious. For example, poorly light areas in a physiotherapy department. Members are accepted to be aware of health and safety rules and procedures and to ensure that both the patient's colleagues and they themselves complete with this. In the course of treatment, patients are encouraged to take calculated clinical risk to take forward the rehabilitation processes and reach their maximum potential. Therapists are expected to assess the risk, to explain them to patients, supervise practice, and to record where appropriate. Risk relating to other personal caring for the patients are also the responsibility of a physiotherapist. This may include the level of staffing required for maintenance of a rehabilitation program, including the safe manual handling of a patient. This must be safe for both the patients, the carers, and physiotherapists. The physiotherapist is therefore required to assess all risks relating to the overall physiotherapeutic care of the patient. In the NHS, any risk identifies that cannot be dealt with by the therapist or the therapy services must be reported by the therapy manager, usually in writing to the appropriate authority In the private sector, any risk identified that cannot be dealt with the physiotherapist should be directed for the referring clinicians and appropriate authority. Now comes the rule number 6. Advertising. Chartered physiotherapists shall ensure that advertising in respect of their professional activities is accurate and professionally restrained. This rule sets out the parameters within which members can advertise. An advertisement must be professionally restrained, accurate, legal, decent, honest, and truthful. Because of the importance of the maintenance of the patient or the therapist relationship, it is unethical to appeal in person to potential patients, whether such appeals are made face-to-face or by telephone. However, advertising via website, leaflets, or advertisement in free newspaper, which can be accessed directly by potential patients, is acceptable. Physiotherapists should publish the profession and the practice of the physiotherapy, but they should act in a restrained manner in respect of their personal professional practice. Rule number 7, that is sale of services and goods. This one is second last. Chartered physiotherapists shall not sell, supply, endorse, and promote the sales of services or goods in way which exploit the professional relationship with their patient. Therapists should not only sell or supply goods or services in clinical practice after they have satisfied themselves that the item in question is appropriate to the individual patient's condition. Any handling charge on the sale of the goods or services should be reasonable. Primarily, physiotherapists working outside the public or employed sector are selling the services of a chartered physiotherapist. Members are therefore accepted to ensure that following a detailed assessment, appropriate care is given. Patient must be informed of the likely length and cost of that intervention, and the fees charged must be reasonable. Sees the threefold responsibility of chartered physiotherapists as set out of rule number 4. Excess charging or overtreatment could facilitate a complaint alleging contravention of the rules. This rule refers expressly to the clinical constant and the supply of appliances, supports, etc. to the patients and to charging of them. Within the NHS, there are clear guidelines set down for the supply of this goods and the charges to be paid. Within the private sector, it is reasonable for a handling charge to be added to the cost of an item. It would, however, be unethical for a markup to be made that was so high as to constitute exploitation of the relationship with the patient and to go beyond a normal commercial good practice. Rule number 8, personal and professional standards. Therapists shall adhere at all times to personal and professional standards which reflects credit on the profession, behavior, approach, and stress should not cause offense to the patient and career. This rule has been deliberately framed as general statement, recognizing that it is impossible to specify in precise terms everything that could be considered to be professional misconduct now and in the future. The following provide examples of incidents that may be brought to the attention of the chartered society and it could be lead to the professional disciplinary procedure which being involved. The following provided the example of incidents that may be brought to the attention of the chartered society and which could lead to the professional disciplinary procedure being involved. Conviction by the court, this is the conviction by the court, and thank you.